None of those is more glaring or important than in cancer care. Steve Patierno has the unique background of having lots of experience in Washington, but also being a leading researcher and leader in improving clinical practice. And this is a great example of the confluence between what's going on clinically at Duke in cancer care and the opportunities for national leadership, and not only reimagining better ways to deliver care, but actually getting the payment and other policies in place to make it happen here and around the country. Steve?
Thanks, Mark, and thank you again, Dr. Margolis, for your support. I had forgotten about your stint at the NCI, so I'm a little bit nervous here, because obviously you know something about cancer. Adds special stress. Most of you know that when I talk, I usually talk way too fast. I use my hands, and Vicki said I throw out too many ideas too fast, so she penalized me and said 1 slide. So I get 1 slide, but what I did is I told Mark, okay, I'm going to punish you, and I'm going to actually prepare a couple of remarks. So I actually wrote some stuff down, so forgive me for reading those, but I want to cover the main points. So, all right, over the past 2 decades, the Institute of Medicine has released a series of reports ranging across the cancer continuum, from prevention, screening, early detection of cancer through cancer care into survivorship and end of life. A common thread through each of these reports is a serious absence of coordinated care and communication between primary care clinicians, cancer specialists, resulting in a fractured and suboptimal care of patients before, during, and after cancer therapy. This includes suboptimal emphasis on prevention, suboptimal emphasis on community health and cancer care, and suboptimal emphasis on access to care. Very excited when I saw the early slides from Rob Saunders that mentioned primary care specialist communication, and listening to Brady talk about community health workers. And I've already got ideas. We're going to email and set up some things to do together. This is a global problem. It's not specific to the United States. The complexities of care will exponentially increase as new innovations and technologies are introduced, such as precision medicine, risk-stratified cancer screening, cancer interception, that is early detected cancer that can be intercepted with interventions that can slow tumor growth, management of multiple comorbidities of patients on targeted therapy or immunotherapy, care of cancer patients on chronic therapy, and the rapid growth in the number of cancer survivors that is currently overwhelming the medical system. As of today, there are 16.5 million cancer survivors in the United States, and as a nation, we have done almost nothing to prepare for how we're going to care for this huge block of people with extensive complications and long and late-term effects of cancer treatment. This issue in lack of communication is one of the singular barriers to improving quality of care and outcomes across the whole continuum. And as our healthcare system in our country evolves, the need for an integrated approach for cancer care, uniting cancer specialists, primary care clinicians, is echoed by accountable care organizations, healthcare networks, and the Duke Cancer Institute, working with DOHS and the Margolis Center, is poised to play a pivotal role in advancing high-quality care throughout the cancer care continuum. So the mission of our policy initiatives will be to develop and deliver evidence-based, patient-centered, personalized healthcare across the cancer continuum by, number one, enhancing access to care, using what I call a to and through model of longitudinal patient navigation, enhancing the interface between cancer specialists and primary care physicians, identifying key areas where good practice is not aligned with payment, and explore opportunities to evaluate payment reform, including the CMS oncology care model, to conduct innovative research with cutting-edge technology that can be translated into cost savings and address the quality value proposition in cancer care. And lastly, to train and educate the next generation of clinicians and researchers to extend this mission. Our goal is to focus on practice-changing strategies and quality improvement pilots that can be integrated into a rapidly changing healthcare system and facilitate implementation of evidence-based best practices for cancer screening, cancer treatment, and development of algorithms for management of common non-cancer comorbidities that modify the risk of long-term and late effects of cancer therapy, and to engage in population health management. Once again, how are we going to manage the 16 million survivors in this country? Our Epic medical record, EMR, and health information technology, including digital innovation in e-health and mobile health, will be integral as we evaluate decision support tools, the use of patient portals like MyChart, and modes of communication that can link our oncology care providers with our primary care physicians, and make sure that our primary care physicians are triangulated in a real-life manner. On the front end, making the key decision-making points in cancer screening, what to do with diagnostic information and what treatments to undergo in terms of cost and efficacy, and all of the pieces that go into the kinds of decision-making that Peter has emphasized, and kept in a triangulation all the way through the cancer treatment, so that we no longer diagnose a cancer patient, pull them out of primary care, stick them into a cancer center for a year and a half, treat them with really, really hard treatments, and then say, hey, look, we did really well, see you later. And they go back to their primary care physician and they have an enormous spectrum of problems that we've given them as a function of treating them for cancer. So we want to make sure that our primary care physicians are looped in, and we believe that this could result in cost savings, increased care efficiency, and a much more patient-centered approach to cancer care. This will draw on a number of important initiatives that we have started. One has been started already. It's called the Center for Applied Cancer Health Policy, led by Youssef Safar. He's addressing things like affordability, value-based care, impact on patient-provider decision-making, and payment reform in the quality value spectrum. We have a new program called the Cancer Patient Experience Research Program. We call it CPEP, led by Tom LeBlanc, that's incorporating patient-reported outcomes into real-time health systems in a learning laboratory. And then finally, a new entity that we've just launched called the Quality Cancer Care Research Program, led by Arif Kamal, who was mentioned earlier, and this is specifically looking at quality metrics in very focused applications of evidence-based medicine. And then the last piece is laying the groundwork for what will become an onco primary care center that will focus on care redesign, longitudinal incorporation of primary care across the care continuum. So that's sort of the overarching efforts we're doing at DCI, and Dr. Greenup is going to come and give you a specific example that she's working on to give you a sense of what legs look like underneath these kinds of high-level interventions. Thanks. Great. Rachel.